So I'm really excited. This is my first grand rounds as a faculty member to present work that I've been doing. I've titled this talk, Frontotemporal Dementia, Psychiatric Symptom Clusters and Targeted Therapy. So I've been really lucky to be funded by the NIH, and now I'm at K23, which provides all the funding for my research. I'm also receiving, the one disclosure is Lundbeck, the company that makes 40-oxetine, is giving material support to the clinical trial that I'm starting. So no fees or research funding, but they are generously providing the study drug. And everything I talk about today will be off-label because there are no approved treatments for frontotemporal dementia. So these are the CME approved objectives, and I think they ring true to what I hope to do. The first is I'd like everyone to leave here with some understanding and some ability to describe the phenotypic, genetic, and pathologic heterogeneity of frontotemporal dementia. I want to lay out what this illness is, so we all have a frame, kind of a common frame to work from. I'd like everyone to be able to recognize the existence and the importance of identifying discrete psychiatric symptom clusters in frontotemporal dementia, and finally be able to evaluate the potential for targeted psychiatric treatment in FTD, which is what I really hope to accomplish in the years to come. All right, so let me start out by just giving a brief description of frontotemporal dementia. So it's really a broad umbrella term that encompasses an array of diverse clinical syndromes. It's not one thing. We can think of it very generally as a disorder that presents with progressive changes in behavior, executive function, or language. But there's many disorders that are subsumed within this umbrella. And the diversity is in part explained by complex and varied genetics. So I've listed here 3 of the most common autosomal dominant mutations that can lead to FTD, although the majority of cases are sporadic. So there's this significant genetic diversity that leads to quite diverse underlying clinical neuropathology. So there can be abnormal tau inclusions and pathologic TDP43 inclusions, which are the primary pathologic findings, which again lead to different symptoms, different presentations. So all of this, the mix of genetics and pathology, lead to quite divergent clinical phenotypes, some of which are primarily behavioral, some are language, and some that also include motor symptoms. So it really is a broad illness, and I think it's important to appreciate that. So some basic epidemiologic facts about FTD. It's thought of as one of the most common young onset dementia, so dementia that presents under 60. And the average age of onset is around age 56. That being said, there's some emerging epidemiologic evidence that the majority of people living with FTD are in their 70s. So yes, it is a common cause of the very rare form of dementia that presents under 60, but the majority of people living with this illness are in their 70s. Similar to what we see in Alzheimer's disease, the median life expectancy is somewhere in the 8 to 12 year range. That's also quite a broad range, and an average that doesn't really help us prognosticate very much, because some patients live much longer than that and some shorter. The group with comorbid ALS, I'll talk about this a little bit in a moment, are the one exception where progression is much faster. So if you look at most of the literature, most commonly it's quoted that 30 to 40% of cases are familial. And again, I'm listing the three most common autosomal dominant mutations. Although again, there's emerging work that probably it's a smaller percent that are familial, maybe as small as 10%. So the majority of people, and maybe the overwhelming majority, are sporadic. We can't explain this with a simple autosomal dominant mutation. And especially for a room full of psychiatrists, I think it's really important to appreciate that there's a fairly significant phenotypic overlap with primary psychiatric disorders. And I've listed some of them here. There are most, I think, well-trained psychiatrists, when they see a patient with FTD, they know it's different. This isn't what they're used to seeing, but there can be a flavor that's not dissimilar to late-life bipolar disorder, late-life depression. Sometimes there's these intense ritualistic compulsive behaviors that can look a little bit like OCD. Rarely there are hallucinations and delusions, which again can look a lot like schizophrenia. So it's not uncommon that patients are initially diagnosed with a psychiatric condition. So I'm going to now go and I'm going to list the 3 primary phenotypes that we see. And the focus of my research and the focus of the talk going forward is going to be on this behavioral variant of frontotemporal dementia. This is the most common form of the illness, and I think it's what most psychiatrists think of when they think of this disease. And so the definition in terms of how we diagnose it is based on these consensus criteria. So you just need to have 3 of the following symptoms: disinhibition, apathy, loss of sympathy, perseverative or compulsive behavior, hyperorality, or executive dysfunction. There has to be evidence of progression, and you can't explain the illness with any other underlying condition, a psychiatric diagnosis or a neurologic diagnosis. But just the presence of those three symptoms and evidence of a progressive course is enough to meet diagnosis of possible BVFTD. And then if you have evidence of frontotemporal atrophy or hypometabolism, that's a diagnosis of probable BVFTD. So I point that out that it's diagnosed not too dissimilar to some of our psychiatric conditions, in that a lot of this is just going through symptoms and diagnosing based on our best estimate of what's going on. So in addition to the behavioral variant, the most common form, there are two forms of primary progressive aphasia that are subsumed within this FTD umbrella. And those are the semantic variant of PPA, primary progressive aphasia, and the non-fluent variant. And we heard from Dr. Lennard, it was initially thought that his symptoms may be explained purely by this primary progressive aphasia diagnosis. So the semantic variant, you can think of it a little bit like, in simplistic terms, like a Wernicke's aphasia, where the speech remains fluent, but it's vacuous. There won't be a lot of meaning or content behind the speech. There's often impaired confrontation naming, so if you show someone a series of items, they won't be able to tell you what they are. And this presents kind of as we would expect, given kind of the neuroanatomic correlates with the anterior temporal lobe atrophy and hypometabolism. And then the other form of PPA that falls within FTD is non-fluent variant, which in again, simplistic terms, we can almost think of as like a Broca's aphasia. There's effortful, halting, agrammatic speech. The content of the speech is there, but the motoric aspects of producing the words is impaired. And as we'd expect, again, given the neural correlates of motoric speech production, it's early on changes in the left frontoinsular where there'll be atrophy or hypometabolism. So when we think about traditionally how people think of FTD, it's this behavioral variant, these two language variants. But the reality is it's much more complex. And I'm not going to dwell a lot on this slide, but I just want to show it. This is from a colleague, Brad Beauvais, and colleagues who's at Mayo Clinic. This is really a diverse, heterogeneous disease, and you can see this big circle on the right here with behavioral variant, but there's significant overlap with the language variants. You've got this group of atypical Parkinsonisms. Many patients in my clinic meet diagnostic criteria for PSP or cortical basal syndrome. Again, many of whom present with the BVFTD syndrome. There's this overlap with ALS. There's other variety of movement disorders that can be Parkinsonian or hyperkinetic and overlap with Huntington's. And traditionally, we've thought of FTD as sparing memory. That's kind of been the traditional thought, but there's growing evidence that it doesn't necessarily spare memory, and there can be a group that have really prominent amnestic syndromes that overlap with Alzheimer's. So all of this is just to say that this is a complex illness, but it's often not purely speech, purely behavioral, purely motor. There's tremendous overlap, and in almost all cases, significant behavioral and neuropsychiatric symptoms are really relevant to the disease course. And so that's why it's the focus of what I do, and I think it's really important to think about and study. Okay, so I've laid out, at least a basic framework for what FTD is and how I conceptualize it. It's not simple, but hopefully it's a little bit more clear now in terms of what we're dealing with. And so I'm going to move on now to talk about work I've done over the last 2 years, which I was very lucky to come onto faculty with the KL2 and start to study and try to understand the existence of psychiatric symptom clusters in FTD. And so, again, I came onto faculty, and I got to join this group, a study called All FTD, which Dr. Chadianike, who's here, is our site PI for. This is a really terrific study. There's about 28 sites in North America now where patients with FTD and related disorders come in roughly annually, and they get quite detailed cognitive testing, psychiatric testing, neuroimaging, and they're followed longitudinally. So we get this really rich data across the disease course of what's going on in FTD. And I was starting to see patients and seeing, frequently the really significant occurrence of neuropsychiatric symptoms. And so I wanted to study that a little bit and look at whether the clinical experience that I was having in clinic matched what was being experienced in patients in the study kind of across time. And so here I've just listed kind of more or less a kind of a laundry list of different symptoms that are captured in the All-FTD study and that occur commonly in patients coming into clinic. You can see here symptoms like apathy, disinhibition, irritability, motor disturbances, hyperorality, which is a very interesting symptom in FTD, depression, anxiety, agitation, these ritualistic compulsive behaviors, sleep disturbance, elation, and psychosis. And you can see they're quite common even early on in the illness, and even more so for most of the symptoms in advanced stages. But what was most interesting to me is that they're quite diverse. Some of these symptoms almost are counterintuitive, or you wouldn't think of them as of co-occurring. And that fit what I was seeing in clinic. When people walked into clinic, they often had a certain cluster of symptoms that made sense phenotypically, but there had never been really careful work to discern, are there very discrete psychiatric clusters or phenotypes that come in that might help us understand the underlying neurobiology and perhaps help develop targeted treatment. So that was the underlying hypothesis or motivation for undertaking this work. And so I'm going to present a series of tables now from a paper that was actually good timing. It was just accepted last Thursday in the Journal of Psychiatry and Clinical Neurosciences. This is an all-FTD paper that I led with wonderful collaborators across the country. And so I'm going to march out the findings from this, which I think are really exciting. So the first thing, this is a similar list of symptoms that I just showed, but what we're looking at is their prevalence across the disease course. So you can see up in the top here, the CDR-FTLD is a marker of disease severity. 0 is no dementia, 3 is severe dementia, and 0.5, 1, and 2 are in between. And there's some interesting patterns that occur over time. The ones that are highlighted here, there's statistically significant differences across the disease severity. So you see depression, interestingly, peaks in early disease and then tapers off, whereas symptoms like hyperorality or these obsessions and compulsions are increase to being present in 80% or more of patients in advanced disease. But the big takeaway here was, as I hypothesized and was seeing in clinic, that these symptoms occur in clusters. They're not occurring in isolation. And even in early stage illness, you can see the overwhelming majority of patients have 3 or more neuropsychiatric symptoms at a time, at a single visit. And that, it's up to over 70% even in this questionable disease state, and that's close to 90% in advanced stages. So these symptoms are occurring in groups, and so it gives some idea that maybe it makes sense to really hone in on what these groups might look like. The next thing I wanted to look at, again, just to treating patients in clinic is very self-evident that these are important things to study. These symptoms cause a lot of suffering for patients, but I wanted to just show empirically how much of an impact they have. And so one of the measures that we have in this study is a measure of caregiver burden. So again, this is not just something that the patients are experiencing, but it's something their families experience as well. And there's an inventory called the ZBI, or the Zarit Burden Inventory. It's a 22-item questionnaire, which gets at a lot of really nuanced ways in which these kinds of symptoms or these diagnoses can affect caregivers. And it breaks them down into four domains. There's the emotional impact on the caregiver. There's the social impact, because it can absolutely affect social circles and social interactions. Financial impact certainly can be a big part of it. And then there's actually the health, the primary health of the caregiver, because oftentimes it's easy to neglect yourself when you're caring for somebody else. And the takeaway here is really across all of these different symptoms, caregiver burden is higher in the presence of the symptoms, and that reaches statistical significance when you look at symptoms of agitation, apathy, disinhibition, and irritability. So we know these symptoms are common. They cause suffering for the patient, and they significantly impact caregiver burden. And so just to again kind of convince myself and everybody else how important these are, there's also an impact on functional ability. And so there's a questionnaire again in this data set called the Functional Activities Questionnaire, which again looks at a variety of different domains in terms of how functioning in life at home, everything from cooking meals to feeding oneself to walking without falls, more complex activities like transactions, paying bills, shopping. And again, the pattern is similar. Almost across, without exception, the presence of these symptoms is associated with worse functional ability. And that's statistically significant when we look at apathy and particularly hyperorality and obsessions and compulsions. So again, these symptoms they're common. They occur in clusters. They're impacting the patient, their caregivers, and they're not just a personal experience. They impact functional ability. And then the last thing I'll present, again, just to show the importance, and I hope this projects okay, but this is unpublished data. This isn't from the paper I was presenting. This will be forthcoming. But there also seems to be a signal that the presence of in this instance, I'm just looking at depression and anxiety, the presence of symptoms in early illness may forecast more rapid progression over time. So what these Kaplan-Meier graphs show is in dotted red, these are patients without depression in the early stages of the illness, and in dark blue, blue, it's patients with depression or anxiety on the right. And those that have the presence of depression or anxiety early on are more likely to progress to from early stage to moderate or severe disease. So these symptoms are impactful in a variety of domains, really across the spectrum of what is important for patients and their families. Okay. So now coming back to this idea of clusters, so having proven to myself and hopefully to everyone here that these symptoms are important for a variety of reasons, why is it interesting to think about there being clusters, and what might those clusters be? So my hypothesis early on was that there would be three, and this is based on kind of intuitively the patients that come into clinic. There was a group that had this prominent anxiety, depression, irritability that it thought would fit into this affective group. There was a group that were very develop these compulsive, ritualistic behaviors, often with disordered eating, which we call hyperorality, and then a smaller group, a rare group, but that group that experienced hallucinations and delusions that seemed different. And the reason I thought these were important is that there's likely unique neurobiology that is explaining these symptoms. The standard of care in FTD up to this point has been to do trials looking at behavioral variant FTD as a single entity. So anybody who's experiencing any symptoms within this domain gets a single intervention. And to me, not surprisingly, there haven't been very many effective interventions, probably because I think there's different things going on for different patients. And so if we can show that these discrete entities exist, and we can uncover some specific neurobiology that explains it, it might allow or open up a window for targeted therapy. The other thing I think that's really interesting about this is in a lot of ways it feels like, to me, doing psychiatry in reverse. And in psychiatry, we have this history of this really descriptive phenomenology where we have these really rich, from Emil Kraepelin onward, descriptions of what's happening for the patient, and we're just now trying to uncover what's the underlying neurobiology or changes in the brain that explain that. In NFTD and in a lot of neuropsychiatry, it's the opposite. We know the disease is defined based on this changes in the frontotemporal regions of the brain, but no one's really sat and carefully characterized what's happening with patients. And I think bringing those two perspectives together is really important. And I think that's how we're going to get to a future of more specific and targeted therapy. Okay, so this was the hypothesis that there'd be three clusters. So I'm going to move back to this paper that just came out and explain how these clusters ended up coming about. And so I'll just spend a brief moment. This is a technical slide that's not particularly important, but the idea was we have this hypothesis in mind. There's three clusters, but let's just ask the data agnostically what's going on. Let's not bring any of our preconceived notions and just allow through some really neat statistical techniques to look at what actually exists in the data. And this is I thank Jeannie Luatsakos, who's spent some time with me helping me learn how to do these kinds of analysis. This is a polychoric cluster analysis, and I'm showing here this is called a parallel analysis with a scree plot that's designed here. But really the takeaway is that there appear to be four clusters. You look for the point where there's an inflection point in that curve, and then the parallel analysis has a series of iterations. But again, not baking in the thought that there would be three clusters. The data looked like there was going to be four clusters. So what do those clusters look like? And this is what resulted from that model. And I've named the clusters according to the characteristics of the symptoms. So I'll walk through each of them. So the first, the factor one, I'm calling affective, similar to what was hypothesized, and it's a mix of agitation, depression, anxiety, and irritability. There's a second cluster that we named the disinhibited cluster with prominent elation and disinhibition. A third cluster where more compulsive symptoms were traveled together, hyperorality and obsessions and compulsions, and then a fourth cluster, psychosis, so hallucinations and delusions. And so this made a lot of sense. It makes intuitive sense, but it was really nice to see that our hypothesis and our clinical sense of what was going on is in fact what comes out in the data when we just use these very objective agnostic techniques. And so this was the final result. So actually not that much different than what we hypothesized. The affective cluster more or less is broken into two, where there's kind of this negative affect and this positive affect. But the other three were as expected. So I think that's really interesting because it tells us that what we're seeing in clinic matches what's objectively found in the data, and it supports this idea that there may be specific changes in the brain that underline these different symptoms. And we've done some work already in this compulsive cluster showing some changes in the brain, particularly in the striatum and the insula. I don't have a lot of time to explain that, But I'm gonna focus for the duration of this talk on the affective cluster. And again, the goal is, can we select patients more precisely based on the symptoms that they're experiencing, and test agents that are targeted directly at that subgroup, and hopefully develop more effective treatments. So I'm gonna finish the last part of this talk talking about the goal of moving forward and developing these targeted treatments for psychiatric symptoms in FTD. Okay, so again, coming back to these clusters, and I'm going to move on to the affective cluster. And so this is what my funding from the NIH is to study now. And I think it's a really interesting, important group to start with in a lot of ways, because affective symptoms are common, and as I showed in a few slides earlier, they occur early in the disease primarily. They actually taper off in the more severe stages, and early stage is the point where we may be able to have the most impact on functional progression, for instance. So if we can meaningfully intervene here, that could have a real meaningful impact for patients. They're associated with significant caregiver and patient and caregiver burden. I showed that data already, and they're challenging to treat. We don't have great treatments for these in FTD. As I mentioned, most of the research in FTD has focused on, we just put all the people with behavioral variant FTD together. We use a general behavioral symptom scale as the outcome, and we see whether or not there's a difference. But there have been some studies looking at antidepressants, and you can see some of them listed here. This is a nice review or meta-analysis that was done, and there's a signal that probably serotonergic antidepressants are helpful. The evidence is mixed. You can see there's actually been studies of paroxetine where symptoms worsened, but certainly trazodone has been shown to be helpful. Fluvoxamine has been shown to be helpful, and when you look at all the effects combined, there's at least a signal towards benefit. And this is really what the standard of care has been in FTD. You try an antidepressant in just about everybody, but I thought these kind of mixed results suggest that I think the serotonergic agents warrant more study. And in particular, we should be more precise and discerning in who we give these serotonergic agents to. There's a reason to think that serotonin is important in FTD. There's a profound serotonergic deficit. So this is a paper. On one side is a paper from my colleague in England, Alex Murley, looking at serotonergic deficit in PSP patients with FTD. The other is comparing patients with Alzheimer's disease and FTD. So Alzheimer's disease also has a significant serotonergic burden, but FTD is much, much greater. So I won't go through all the details, but it's across different brain regions, particularly amygdala, hippocampus, areas that are important for anxiety and depression. The serotonergic system is pretty devastated in FTD, including changes in the Raphe nucleus, kind of the epicenter of serotonin production. So there's reason to think that these networks are affected broadly, and that there's a reason to think that supporting the serotonin system would be helpful in FTD. The other thing I'll touch on briefly, and some of you may have noticed this, that apathy was kind of conspicuously missing from all of those clusters I showed you. And the reason, and apathy is almost universal in FTD, and we heard a bit about that from our patient today. And the reason for that is apathy is not really unique across different symptoms. Almost everybody, regardless of what prominent symptom they're experiencing in FTD, has some level of apathy. And apathy is one of the most difficult symptoms to treat across neurodegenerative disorders. And we know traditional SSRIs don't work. And so, again, thinking about can we take this idea of serotonergic agents being helpful, but maybe not using traditional SSRIs, but something that's a little bit different. Maybe we can meaningfully impact the affective symptoms, and as a secondary idea, maybe we can have an impact on apathy, which we know we haven't successfully done with traditional SSRIs. So that whole construct is what got me interested in this idea of multimodal antidepressants, and particularly the drug vortioxetine, which I'll spend a little bit of time discussing now. So again, we know serotonergic dysfunction is really significant in BVFTD, and it could be that modulation of multiple serotonin pathways could be more effective. So like SSRIs, vortioxetine has SERT inhibition, so it has the same kind of prototypic mechanism that SSRIs have. But in addition to that, there's agonism at the 5-HT1A pathway, partial agonism at the 5-HT1B, and then antagonism at 5-HT3. 1D and T7, and this is kind of a fancy cartoon of all the ways in which vortioxetine impacts the serotonergic system. So we don't really know. No one's really studied what is the effect of that. We know it's a reasonable antidepressant, probably not dramatically different than the ones we use for depression and anxiety. But could these different mechanisms have a bigger impact on neurodegenerative illness, particularly FTD? And there's some reason to think that it might. So one interesting characteristic of vortioxetine is that it's been showed consistently to have improvements in cognition above and beyond just improvements from treating depression. So there's been a variety of studies. For some reason, there's been multiple studies comparing duloxetine to vortioxetine, and similar antidepressant properties, but vortioxetine tends to improve a variety of cognitive domains, in particular executive function and attention, again, above and beyond what we just see from treating the depression. So that's interesting, and there's some idea that 5-HT3 antagonism may confer some pro-cognitive side effects, or pro-cognitive effects, and there's ways in which that can manipulate the cholinergic system and a variety of other neurotransmitter systems. There's been some small studies. Again, this is by no means well established, but there's been at least one or two small studies where vortioxetine has effectively treated depression and Alzheimer's disease, and that's really unusual. SSRIs, the work using SSRIs in Alzheimer's has been spearheaded here at Hopkins by Kostas Laketsos, and there's no question that SSRIs are helpful, but they're not helpful for depression. They're actually helpful for irritability and agitation and some of the other symptoms. So it's interesting to see that there's some signal of maybe some budging of depression and Alzheimer's with vortioxetine. And then there's a separate study that has found some meaningful improvement in apathy, again, with patients with Alzheimer's disease, which again is not typically seen with traditional SSRIs. So for all of these reasons, I think there was interesting reasons to explore vortioxetine's effect in FTD, which has never been done. No one's ever done that before. And so that's what led to the hypotheses underlying the current study that Dr. Lenar is referring to, that I'm really excited to be embarking on. And so the goals of this study are to first identify the underlying neural circuitry that is associated with anxiety and depression, these affective symptoms in early BPD. Again, we want to start by understanding what changes in the brain might explain these symptoms. And we have some hypotheses that changes in the salience network and the default mode network are maybe particularly important in the development of these symptoms. And then patients will undergo pretty careful cognitive assessment, fairly deep psychiatric phenotyping. They'll have an FDG PET scan and a structural and functional MRI, so we'll get a lot of data beforehand, and then they'll be treated in an open-label fashion with vortioxetine for 3 months. So everybody will get the drug. So this is a pilot study, so there's no blinding, which is nice to be able to approach patients and say, we know you're going to get something. And then we're going to repeat all of those assessments after the 3 months period. So repeat the cognitive testing, the neuropsychiatric evaluation, and the imaging, in the hopes that symptoms will improve first and foremost, and perhaps there'll be changes in neural circuitry and metabolism in these relevant brain areas, which would be really exciting if we show that. And so it's been a fair amount of work, but we're now just about officially starting this. And I think this is just the beginning of the story, because I think there's a lot of additional exciting avenues to explore in FTD. Again, as I showed, there's these four clusters, and I think the affective symptom is just the first, and the serotonergic system is just the first. There's all kinds of agents that we could explore. And I think subtyping the patients and being very discerning in the group that we're targeting could lead to some different changes. So in the past, again, things like lithium have been given to all patients with behavioral variant FTD, and there's been mixed results. Perhaps if we're just targeting that disinhibited elated group, we'd have different findings. Similar with memantine and amantadine, both of which have been tested, but again in all comers. So again, maybe if we're a little bit more targeted in the groups that we look at, we would have different results. So I think there's lots of agents that could be explored. I also think the potential for non-invasive brain stimulation, and if we can uncover these relevant networks, perhaps we can do it even without drugs, and again in a very targeted, specific way. So I think the future is really exciting. I'm focusing on this vortioxetine trial as a start, but lots of interesting directions to go in. And with that, I just want to thank a wonderful team. My mentors have been incredibly supportive. Chadia Nike, Arnold Bacher, and NVIDIA came out with incredible support. Greg Pontone, who's down in Florida now, has been a wonderful support of mine. And the whole Bacher lab, I think many of them are here, especially Carrie, just incredibly welcoming, really helped me get this trial started. And I'm very, very grateful for all of them. So with that, I'm happy to answer any questions.
Wow, that was a spectacularly good first grand rounds, Dr. Morrow. That was really, really interesting. Thanks. Let me ask you a question. As you know, I'm a mood disorders subspecialist, and I'm thinking, but of course, depression is probably the most common thing all of us see. And if we have a 60-year-old come into the office, again, as you know, it's not uncommon. If they come in for depression, their motivation is likely to be low. Irritability is a prominent feature, poor concentration. What's your threshold for deciding someone should, what would be our threshold? What should be our threshold for deciding someone should get brain imaging to consider the possibility that you...
Yeah, it's a great question, and so I would say my threshold would be if there's really any prominent memory complaints or prominent just cognitive changes that the patient or their caregiver spouse endorses. I think I'd have a very low threshold just to do basic structural imaging, whether that's a CT or an MRI. If there's no cognitive complaints, I would try traditional treatment. But if it's really not budging at all, and this is just not following the course that we would expect with a typical depression treatment, again, I think there should be a pretty low threshold. Granted, if you see generalized atrophy, it's not going to change your management a whole lot. But again, there are. I more worry about missing something unusual, like some kind of malignancy or an inflammatory process. Again, it's very, very rare that it happens, and so if there's things that are just not quite right, it's just not fitting the pattern that we usually see, I have a pretty low threshold. So.
Okay, thanks. Other folks have questions. Dr. Lipsy.
No, it's a great question. So the question Dr. Lipsy asked was whether we see pathological laughing or crying. Sometimes that's referred to as pseudobulbar affect. It's not common, but it can happen in brain injury and some other conditions. I would say that that's not something that I regularly see in FTD. I think there are certainly inappropriate social interactions where there's this inappropriate jocularity, kind of cracking jokes and being inappropriately familiar with people. That is a phenotype, but not so much the uncontrollable laughing and crying. Although I can say, I see Seema here, we've had 2 patients that we've treated this year who just this uncontrollable sobbing all day long. So I'd say it happens, but it's not routine, and it's very, very hard to treat in my experience. And I haven't had a tremendous amount of luck, but we often start with serotonergic agents. So.
Great, thanks. Dr. Redgrave.
Thanks, Dr. Morrow. That was awesome. In terms of the sort of goals of the trial, is the hope that ameliorating symptoms that tend to occur early in the course of illness, it's going to have a disease-modifying effect, or is it really that the goal is to improve quality of life for as long as possible?
Yeah, it's a terrific question. So Dr. Redgrave asked if the goal with this trial is to have a disease-modifying effect, so maybe dampen the course, or is it really to focus on quality of life and symptom improvement? And so I would say certainly my overarching goal is to budge the disease trajectory if we can. And again, that is, I think if we can treat those symptoms symptomatically, improve quality of life, that's going to increase functional abilities, socialization, physical activity, all of which we know actually do modify the disease course. So my hope is in an indirect fashion, we'll get both. And maybe if there's a pro-cognitive effect of this medicine, which is one of our secondary outcomes, it could well be that this improves things in and of itself through the mechanism of the drug. But I don't know. So it's aspirational, but certainly hoping for both. But focusing on the symptomatic improvement as the primary outcome.
Great, thanks. Dr. Henkel.
Yeah, it's a terrific question. So Dr. Hinkle very astutely noted that the factor loadings for the psychosis cluster were very, very high, or 0.99, which means that these symptoms travel together very tightly. And I think there's a couple of reasons for that. I think one, it's a relatively rare subtype, and so I think when those symptoms do occur, they occur together and not in isolation, but in relative isolation. And I think there's some interesting reasons for that. So it occurs almost exclusively in people with TDP-43 pathology. So I do think there's a neuropathologic correlate that we know of, probably more common in people with a C9orf72 mutation. And so my suspicion is, and it's not uncommon actually to occur in comorbid FTD ALS, and I've had several patients with these really incredibly rich and surprisingly descriptive hallucinations and delusions with FTD ALS. So my suspicion is it's a mix of rather specific neuropathology that has an impact on specific networks that causes just a different phenotype than the majority of people with FTD. So I wasn't too surprised to see that those factor loadings with those symptoms.
Great, thanks. Question? Yeah, go ahead.
Yeah, that's a great question. So Dr. Fields asked, when we're looking for these symptom clusters, how do we take into effect past history of depression or obsessive symptoms or anxiety? So the way these cluster analysis was done is it's based on a neuropsychiatric inventory questionnaire that the clinician went over with the caregiver about symptoms in the past month. So it's all based on symptoms that are currently occurring or have occurred in the last month. So it's not taking into account past symptoms, which I actually think is important because there can be some fluctuating nature to some of these. So the findings are really relevant to clusters of symptoms that are co-occurring in a single moment in time with patients based on what they're experiencing last month. I think it's really interesting to think about, what if they've had depression for 30 years and they're still having it? That may well affect kind of where that symptom slots in. But yeah, it's a good idea. We probably should explore that some more. And there's interesting work looking at past psychiatric history in FTD.
Got time for one more? Yeah, go ahead.
Yeah, go ahead, sorry.
Is it more like do we see it in one cluster or another?
It's a terrific question. So Seema asked how lack of insight factors into things, and do we see that more in one cluster than the other? And that I haven't looked at that empirically, but I can say from my own experience, the group with kind of these elated, disinhibited symptoms, in my experience, tend to have very little insight. There's a bit of obliviousness to just the social faux pas. I can think of a patient who wanted dessert and was at a restaurant, and they were ordering appetizers, and he said, "No, I want dessert," and just wandered into the kitchen to go get dessert. And there wasn't a lot of insight into whether that was an appropriate behavior or not. Whereas people experiencing more of this anxious irritability, they tend to be aware of it, and it's uncomfortable, and they don't like it. Similar with the ritualistic compulsive symptoms. So I think it does vary, and we should study it empirically. That's a great idea.
Thank you. That was wonderful. Great talk. Good luck with this study.